Hello, everyone. Welcome to our presentation on consumers' intention to adopt blockchain-based personal health records and data sharing, a focus group study. I'm Dr. Victoria Lemieux from the University of British Columbia, and I'm here presenting today with Dr. Chang Liu, also from the University of British Columbia. Okay, great. Our agenda today will give you a bit of a background on the research that we've conducted, the research objectives. We'll move to methods, findings, discussion, and conclusion. And then at the end, if there's time, we'll take questions. So first of all, the context of the research. Dr. Chang Liu, who is leading the research, is with blockchain at UBC as a postdoctoral research fellow. And he's funded through MyTax Elevate by Boehringer Ingelheim, which is a large pharmaceutical company. Move to the next slide. We also have funding support for this project through Molecular U, a personalized health care AI-driven company, Canada's Digital Technology Supercluster, NSERC, and of course, as I mentioned, Boehringer Ingelheim and MyTax. So at this point, I'm going to turn it over to Dr. Liu to continue the presentation.
Okay, thank you, Vicky, for the beginning. The topic of this presentation is about consumers' intention to adopt blockchain-based PHR and data sharing. So first, we would like to define PHR, personal health record. Personal health record, PHR, refers to electronic applications through which individuals can access, manage, and share their health information, and that of others for whom they are authorized in a private, secure, and confidential environment. So this is a well-recognized definition of PHR by Chang et al. 2006. And then blockchain, as we know, is a immutable distributed ledger. This is a very simple definition of blockchain, but I think this one really represents the essence of blockchain, a distributed ledger. Personal-based health record has been a very popular concept in the health information field. And there have been a lot of attempts to implement personal health record systems. But currently, these existing PHR systems have problems. First, most of these systems use in-memory or cloud-based database technologies. And because of that, they expose patients to privacy and security risks of a single point of failure. In other words, when the central database or the central cloud is tampered or collapses, then the data will be leaked, and then patients' privacy and security will be endangered. And also, the existing PHR systems have limited potential to transfer ownership of healthcare data to healthcare consumers. So these systems rely on large organizations to maintain the system. And the cost of maintaining the system cannot be really bared upon by individual healthcare consumers. So in that sense, because of that, healthcare organizations, health authorities, governments will continue to be the owners or the custodians of healthcare data, and individual consumers will only have limited capacity to really manage their healthcare data. And then these systems have the problems of data silo and fragmentation. Different health authorities use different PHR systems, and these systems sometimes have different infrastructure, and they don't really talk to each other, and that leads to data silo and fragmentation. And also, currently, when it comes to healthcare data sharing, a lot of times healthcare consumers' data are being improperly used by third parties, like research organizations or pharmaceutical companies. These third parties would use consumers' data without consumers' consent, and this is being repeatedly reported in the media. So compared to the existing PHR systems and healthcare data sharing, the blockchain-based PHR systems and data sharing would have the following advantages. First, because blockchain uses cryptography, peer-to-peer network, and multi-tree structure, it will really ensure it will really decrease the risk of data breach, falsification, and tampering. So all these technical components will make sure that once the data is imported into the blockchain, no one will be able to change it by their discretion. And if they make changes, then all the nodes on the chain needs to validate the changes. So that will ensure the trustworthiness of the data. And also because of these technologies, cryptography, peer-to-peer network, and multi-tree structure, the blockchain-based PHR system have this ability to resist any, it can still be hacked, but the risk of being hacked is significantly lower than the traditional PHR systems based on cloud-based technology or data-based technology. And also, blockchain-based PHR can, on a blockchain-based PHR system, healthcare consumers will be the nodes of the peer-to-peer network. So because of that, they can be the custodians of their healthcare data. This is in contrary to the existing PHR systems where large organizations maintain a database, so they have a lot of control over consumers' data. And then in a blockchain-based PHR systems and data sharing systems, usually smart contract will be deployed. And by using the smart contract, we can make sure that any data sharing activity will be initiated by and authorized by healthcare consumers. Only the consumer and only the data can be shared when the consumer gives consent. And also, we can combine smart contract and tokenization on a blockchain-based PHR system and data sharing system. So we can reward data sharing behaviors so that individuals can be more motivated to share their data with researchers and health professionals. And that would facilitate healthcare research and also healthcare information management. So given all these advantages of blockchain-based PHR system and data sharing, the literature, there has been a lot of discussion about blockchain-based PHR data sharing in the literature, but so far the attention is really focused on how to technically design a blockchain-based PHR system, which platform to choose, and which protocol to work with, all those kind of technical questions. And there have been, and in practice, some of the key organizations like Mayo Clinic and University Health Network have implemented pilot blockchain PHR projects. So in practice, there has been, so that means that practitioners and managers have been given increased attention to blockchain-based PHR and data sharing. But so far, little is understood about consumers' adoption intention. So we didn't find it much research that is really look at blockchain-based PHR and data sharing from a consumer's perspective. We don't know much about, even though we are designing all this fancy blockchain-based PHR, talking about the technical parameters behind it, we don't know much about, if the healthcare consumers, if patients are actually motivated and capable to adopt the applications we are designing. And if they are not ready, if they are not motivated and capable, then what concerns may they have? And also, how can we improve their adoption intention? So we don't know these questions yet. And this is exactly the reason why we conducted our research. So driven by all the questions, all the gaps that I just mentioned, we conducted a focus group study with 26 individuals that we recruited from online and offline communities. So our researchers posted online postings in some of the technology communities and invite people to share their opinions about blockchain-based PHR and data sharing. Also, we recruited students on university campus we posted our recruitment ads in different locations on university campus. And this kind of efforts aimed to diversify our the pool of our participants. And so for the focus group study itself, we conducted 3 semi-structured discussions. And for each discussion, we started with a general discussion about PHR, personal health record, and health data sharing. With the participants, we asked their overall attitude towards PHR and data sharing. If they have heard of PHR, what is their experience, and if they are willing to share health data, and so on and so forth. And then our researchers explained blockchain technology, explained how blockchain can be implemented, can be applied to PHR and healthcare data sharing. And also, we designed a blockchain-based PHR user interface to give the participants a more vivid picture of how a blockchain-based PHR will look like. So this is the kind of a snapshot of the interface that we designed, and we show this to the participants in the focus group discussion. And after that, we asked the participants, their intentions for adoption. Do they like to adopt this blockchain-based PHR system after they have seen the interface and after we have explained the technology? And if they don't want to adopt, what are their concerns? So because the study was a focus group study, a lot of the questions are open-ended, and we invited participants to freely express their opinions. And we explicitly told them that there is no wrong and right answer. All the answers are welcomed. So in total, we run 3 focus groups, 3 focus group studies in different times. And we had 26 participants enrolled. For the first focus group, we had 8 participants, and 8 participants for the second focus group, and 10 participants for the third focus group. And we had 13 male participants and 13 female participants. And most of our participants are in the 25 and 35 age group. And we had 1 participant in the 35 to 45 age group, and 2 in the 45 to 65 age group. And all of our participants hold a college degree. This is probably because we posted our recruitment ads on university campus, and there was a very heated interest from the people who live or study on university campus. And after we finished the focus group study, we transcribed all the conversations that we recorded from the focus group study. And then we did this micro-interlocutor analysis recommended by Wigby et al. 2009. So this method is commonly used in healthcare research to analyze focus group data. So the procedure is as following. First, we read all the focus group transcriptions line by line to just get an basic understanding of the conversations in the focus group. And then we look into the answers to each question. And then we code the answers to each question by participant and also by the types of responses. So each participant will express whether they agree with a statement that the researcher has put forward, or they will disagree. And if they agree or disagree, they would provide explanation, or they would just say I agree or disagree and not provide explanation. And some of the questions invite yes or no answers, so we also coded that. So eventually we had this table. So this is basically the outcome of our data analysis. So from this table, you can see that on the left side, we have all the numbers of all of the questions. And then on the top side here, we have the number of our participants. And then we coded how each participant responded to each question, and in 5 different categories: indicated agreement, indicated dissent, provided significant statement, and suggesting agreement, and provided a significant statement, suggesting dissent, and no response, ambivalent response. So this procedure gives us a very good overview of, give us a very overarching understanding of the focus group discussion. And then after that, we conducted qualitative coding of the semantic coding of the explanations that participants provided. So, if they expressed agreement to a certain statement or question, or to a certain statement of the researcher or other participants, then we semantically coded the explanation, what this explanation means, and then also put them into the same category as other explanations provided by other participants. So we have a couple of key findings. The first key finding is that we didn't see any significant increase of adoption intention after we introduced the blockchain-based PHI idea. So as I mentioned earlier, in the focus group study, we started with general questions like, do you feel comfortable? Have you heard of PHR? And do you like to own your healthcare data? Those kind of questions. And then we introduced a blockchain solution. And then we observed, whether there will be more people expressing interest after we introduced the blockchain-based solution. But our finding is that no. So the baseline interest that we discovered from our focus group participants is that there were 7 people who expressed strong interest in PHR and healthcare data sharing, and 7 were not interested. But then after we introduced the blockchain solution, the number of people who were interested decreased to 4. And the number of those who are not interested actually increased from 7 to 8. So even though we didn't have a very big sample, and probably we cannot really make the statistical inference from the changes of the numbers of the people who are interested or not interested, but at least I think from this we can see that at least in our study, after we introduced the blockchain-based PHR, we didn't see a significant increase of adoption intention. And then based on our qualitative coding, we found that one of the key reasons why healthcare consumers were not, didn't really show significant increase of the adoption intention for was that they were really worried about losing private key, which is a key component of a blockchain-based PHR. And they worry that if they lose the private key, they will not be able to access care. So for example, participant 12 said that there's this phrase, it needs to be dumb-proof. Average users, I lost it, I can't remember my password, it has to be dumb-proof, and I think we should consider cost benefit. If there's no end disaster, if someone uses my data, but it will be disaster if I lose my health because of lack of data. So I think, what he's trying to say here is that if he loses the private key, and then he will be able to access his personal health wallet, and in an emergency situation, for example, he needs to, and for example, he runs into a accident, and his doctor needs to access his personal wallet, but because he's probably unconscious, he won't be able to remember, the private key and give access to his doctor. Then in that case, he won't be receiving any care. So then, blockchain-based health PHR could actually prevent him from receiving the care he needs. And this is what a huge concern of the participants in our study. And then we find that the intention to adopt blockchain-based PHR could increase when private key recovery is possible. So right now, blockchain does not provide this capability to recover the private key. But our participants indicate that if there is a way for them to recover the key, whether it is to provide a fingerprint of themselves, or give the private key to trusted healthcare professionals like their doctors, then they will be more willing to use the blockchain-based PHR. Like for example, this participant 24 said that I guess it could be like scanning your eye or your fingerprint would be like a way to add a second, like a way to recover your key. But would it lower your security of the data? That is a case where someone stole the password to your computer, then for that file, they can create those passwords. But if you lose the key, then you cannot go in the thing. So basically what he's trying to say is that, even if given a fingerprint or given his private key to his physicians, for example, would kind of decrease security, but would expose himself to some security risk. But he's willing to do that because he thinks that it's more important to access care than caring about security of his own data. And also we find that consumers' adoption intention could increase when the personal health wallet is provided by government, Apple, or IBM, not by pharmaceutical or genetic companies. So we see from our focus group discussion is that a lot of participants do not have very good impression of pharmaceutical companies, and they believe that these companies often use health data for commercial purposes. So they are not willing for those companies to host a health data wallet, or they become very important nodes on a blockchain-based PHR system. So like this participant 23 said, no 23 and me genetics, no pharma, that's fucked up, that they did too much for commercial purposes. The next finding is that we didn't find significant increase in healthcare data sharing when we introduced a blockchain-based healthcare data sharing. And after we actually told the participants that blockchain-based data sharing could increase privacy and security. And the baseline interest expressed by the participants was like 3 people were interested, but then after we introduced a blockchain, the numbers stayed the same. And we found that the key reason is that the intention for a healthcare data sharing is mostly influenced by factors independent from blockchain, like the purpose of the third party who are using the data and their public image and whether they are audited, and not by the technical capabilities of blockchain. But in the meantime, participants did express that they are concerned about irrevocability of data access if they share the data through blockchain. So the participant 24 said that if it is a university, they would share. So this participant said that can you cancel the access that you give to someone after giving it to them? Then our researcher said, no, you can't. Then this person said, okay, that would be the concern. So if they cannot, they are worried that if the third party will use the data for some commercial purposes or for some unethical purposes, they will not be, and that will be that will really pose a great risk to their privacy, and they don't want that to happen. And this is something that, at least for now, I think blockchain technology needs to address, to develop the capability to address. And then we also find that the intention to share healthcare data through blockchain can be improved when blockchain develops the capability to revoke data access or impose an expiration date on the data being shared. And also consumers need to know, to be updated about the development. So they need to know that they can revoke access, and then their intentions would increase. And then they will be more likely to share healthcare data if they are rewarded by some non-monetary compensation, like say free medical treatment, third party donating to a good cause. So they like to be incentivized by monetary compensation, but they also mentioned that this non-monetary compensation is very important, and they would like to share the data more if they are provided with this kind of non-monetary compensation. So just a few very quick a few points about our contribution. So the current literature really focuses on technical features of blockchain-based PHR, and they believe that these technical features are the adoption barriers, like computational speed and data storage problems. But our study shows that low adoption intention of consumers can also be a barrier. And as we show in the study, consumers do have relatively low intention to adopt the technology at this point. And also previous studies aimed at technical improvements because they assume that technical barriers are most important barriers. But this study shows that the improvements should be also targeted at human-centered design, should really consider the preference of healthcare consumers. And then our study kind of resonated with this notion of health information altruist that scholars have put forward before. So scholars have recognized that sometimes people share their health information not really for monetary purpose, but for something that is altruistic. In that case, I think monetary incentives might be not as important as we previously thought. So our conclusion is that even though consumers' adoption intention might be low right now, but improvements are possible if technology development, if software engineers and user designers consider the recommendations that we put forward in this study. This is our presentation. Thank you.
Thank you very much for listening to our presentation. We hope you found the results useful. I think we just highlight the importance of consumer literacy and human-centered design in blockchain technology. Usable security is going to be key to adoption going forward. So we look forward to discussion about our results during the conference. Thank you.